And welcome to the Bone and Joint Playbook with Dr. John Urse. Tips for pain-free aging. Dr. John Urse is a board-certified orthopedic surgeon with over 35 years' experience in the Dayton, Ohio area. He is also a clinical fellowship-trained surgeon in total joint replacement from Harvard. This episode is brought to you by
Ted's Authentic Greek Salad Dressing and Marinade. It's healthy, gluten-free, and delicious. You can find Ted's in Dayton, Ohio at Dorothy Lane Markets, Health Foods Unlimited, and Dots Markets. That's Ted's Authentic Greek Dressing and Marinade. Thanks, Ted.
All right, folks, we are back here with another fun-filled episode of the Bone and Joint Playbook with Dr. John Urse. We've upgraded our little backdrop here, and we've upgraded our guest list. Look at how well this guy's dressed. Dr. Urse, why don't you tell us who this guy is over here?
Well, we're pleased to have Dr. Neil Patel. He's a neurosurgeon here in Dayton, Ohio at Kettering Brain and Spine. His background's in brain and spine surgery. And Neil, tell us a little bit about your background for the folks.
First of all, thank you guys for having me here. I really appreciate the invite to come and talk to your population and your clientele about the spine. And so, a little bit about me. I'm born and raised in New York City. I went to medical school in Long Island, in New York College of Osteopathic Medicine. I did a residency in neurosurgery in Columbus, Ohio at Doctors Hospital in Ohio Health. I graduated from there in 2009, so that's a 7-year residency. It's a long time. And from day one, we're doing spine and brains from in that residency. I did a pediatric neurosurgery fellowship after that at Cincinnati Children's. And then I had practiced pediatric neurosurgery after that for about 10 years and then kind of worked my way back into the adult game just to get closer back to home where my in-laws live in this area. And I'm just proud to be part of Kettering Brain and Spine. I've been with them for the last 5 years now, and I'm board certified in neurosurgery and recently just got my fellowship of American College of Osteopathic Surgeons.
So what's the topic for today since we have such an illustrious guest?
Wow, Terry, I thought you'd never ask. We're going to talk about disc replacement or spine fusion. And why would we distinguish between those two treatment options for a patient?
Right. So I think before we even talk about treatment, we really need to start talking about the problem, right? So everybody has neck pain or back pain. Nobody has mid-back pain mostly because the way the anatomy of the spine works is, and let's see if Terry can answer this question.
Oh, no.
Terry, if I was to stop from here to here, what does that piece look like? Say suspension bridge. Wiener dog.
A wiener dog?
Suspension bridge. Okay, so it's actually
a wiener dog.
It's actually a suspension bridge. So think about the thoracic spine. It's like a rib. They have the rib cage. It's almost like a big barrel. So you don't typically get a lot of wear and tear on that area because of gravity. But the neck is holding up the head. So that's going to get a lot of wear and tear. The lower back is holding up everything above that, all by itself, no other support. So all the wear and tear is going to go down here and up here, and that's why a lot of people come in with neck pain or back pain. Now, of course, there's a lot of other important equipment behind those bones and joints, and those are the nerves. And those nerves travel into the arms, they travel into the legs, and there's the spinal cord in that area as well, which basically is all or nothing from that level and below in terms of function. And so essentially with the lower back, when we're talking about the lower back and it looking like a suspension bridge, the reason it looks like a suspension bridge is that curvature that's applied here allows gravity and wear and tear when you're bouncing vertical forces to be evenly distributed. It's like a spring. If you take a spring, you bounce to the ground, it bounces back up. But some people have a very straight spine. So you imagine this being more like a straight stick. And you take that and you bounce it to the ground, and the bottom of that stick gets all those forces applied.
Oh.
And so as a result, the lower part of the spine will degenerate quicker in those patients than the upper part of the spine. When you do have a nice curvature, you end up degenerating the middle part of that curvature. And so that could be sometimes L3, L4. So just to kind of show a little bit of the names, the bottom bone is L5, and then you have the pelvis, which is a ring. So this column rests on the back of a ring, and that's where all your forces end up going, is L5 and S1, or sometimes L4, L5, depending on how you position yourself, where you wear your belt line, how you walk, just your overall body habitus. And so that's the low back issues that most people encounter. And then the neck, because of that curvature, a lot of patients or people, if you will encounter issues at C5-6 and C4-5, which is the middle of the neck bones. So C1 through C7 are all the neck bones. And C means cervical, which is the neck.
All right.
So,
by the way, I would have answered if he hadn't played me with the wiener dog thing. I thought it looked like a saxophone.
Okay, that's a good analogy.
Like.
I mean, again, now I know we're in your basement and we see all of these instruments around us. We have guitars, we have drums, we have pianos. I'm sure there's a saxophone somewhere in the closet over there.
Lurking somewhere, yes.
Yeah. So I agree there's definitely a saxophone component, but that curvature that's involved with the saxophone is essentially what our body has been trying to mimic. And really, we're evolved from a four-legged, ancestor of some form. And so that's essentially what this was, a suspension bridge from the front part of our body when we were bearing weight on our forearms to our back hind legs, if you will.
Now, does everybody suffer from back pain, or is it just something happens to us?
So it's a matter of genetics, it's a matter of wear and tear on the body, and a matter of trauma. So there's a lot of other components, but majority of the issues that can happen in the spine are related to those three things: genetics, trauma, and wear and tear.
Fantastic.
And we did a podcast on pinched nerves, which affect the arm and leg, as you talked about.
Yeah.
Today we're focused more on the disc. So the disc is really that spongy cushion between the bones.
Right.
And that, over time, sometimes dries out or just wears down like a sponge on your counter.
Right.
So what happens when discs degenerate or discs wear down? Then people's symptoms may be more localized to the back as opposed to down the leg, or it could be both. That's up to the imaging and the doctor to determine based on their symptoms.
Correct. So basically the discs are these little jelly-looking cushions between all the bones. And so essentially they are really like jelly cushions. And so I have an example of what we call a disc herniation. So this is the bone above, this is the bone below, and the disc is in there. And so the disc is actually like a jelly donut. If you've ever seen a jelly donut, now in reality in our body we don't have jelly donuts. In reality it's like crab meat on the inside and a rubber band ball on the outside. So have you ever seen one of those big rubber band balls?
Oh yeah.
So you imagine that rubber band ball, and if you're walking and you're doing something and some sort of trauma happens and you squeeze it and there's this crab meat spits out back just like that, and it could pinch the nerve. And you see how, hopefully the video is capturing this, but how that nerve is getting pinched by this herniated disc. So
why doesn't it blow out? Is it something keeping it from just blowing out completely?
Well, yeah, there's also the rest of the muscles in this area, and then the bone in the back prevents it from going anywhere further, but the nerve gets pinched in the process.
Oh,
and so then people get sciatic pain, if you've ever heard of sciatic pain.
Right.
So that's that pain shooting down the butt cheek, going down into the back of the thigh and all the way into the leg sometimes.
So that herniated disc, the same thing other people have heard, it's called a ruptured disc.
Correct.
Or it's a little different than what's called a slip disc, right? Those are when there's more motion between two bones. So
correct.
Either way, the disc is some of the problem here. And then after you've had, enough misery, you usually seek your beauty shop, golf shop, Google consults, and then you finally head to a healthcare professional who then probably would do a good exam, check your muscle strength, reflexes, where your pain pattern is, and then certain imaging studies. So what things after you've done your exam would you usually recommend to diagnose a problem like this?
So oftentimes, and this day and age is more common than not, is that the insurance company requires a lot of these patients to go through a lot of other hoops before they get to me. Regardless of that, I still think it's great for us to intervene in the beginning because we can educate. But they often see chiropractors, they will often go to see a physical therapist before they come to us, and sometimes they'll even see a pain management doctor before they even come to the surgeon. But regardless of that, yes, a clinician has to see that patient and diagnose the problem. And the problem that we end up encountering is that the spine is such a complicated structure. There's a lot of muscles, there's a lot of joints, there's a lot of ligaments. There's a lot of other levels, right? As you saw, there's so many levels here. Which level is the one that's causing the problem? Who knows? Nobody can tell. If we have to do an injection at this level or that level to figure it out, nobody can tell unless you get x-rays. So x-rays are typically our first stop with imaging. So we'll do an x-ray with a front view and then a side view. And then even with that, sometimes we'll get a flexion extension view, which is where we get a side x-ray of the person standing there, bending forward and then bending backwards to see if everything's moving in some form of normal structure. And we'll do the same thing with the neck as well.
Now, does every herniated disc require surgery of some kind?
Not necessarily, no. So some of those patients, and this is kind of another reason why the insurance company has gone this route, is to send them to pain management first or to do physical therapy, because 80% of those patients will get better with physical therapy or with injections alone.
Oh, 80%, wow.
80%.
Okay. And how do I know to go to a orthopedic guy versus just an orthopedic guy?
Well, it's controversial, but in the setting of where I come from, neurosurgeons fresh out of training have done more spine surgeries than an orthopedic spine fellowship trained spine surgeon in their 1 year of spine fellowship. So classically, orthopedic residency entails, and you correct me if I'm wrong, Dr. Urse, 5 years of training within which they get a few months worth of spine experience, and then if they want to pursue spine further, they do a full year after that 5 years of training, and then they have a whole year and then a few months worth of spine in their background. Whereas a freshly graduated neurosurgeon has done it from essentially day one. If they're always rotating through the brain tumor service and whatnot, but for the most part, spine surgery. Even me as a neurosurgeon, 80% of what I do is spine surgery.
Wow. Okay.
And for 7 years.
And for 7 years.
Yeah,
True.
so
There's the time too.
Don't sell yourself short. I used to say, the only way to get someone from the East Coast to the Midwest is to move the ocean. So somehow we got you here. So let's tap into some of that knowledge. So now we've gotten an idea where the problem is, and this could be a neck disc or a lumbar, low back disc. Right. And then if we historically would say the problem is the bones are grinding because there's no cushion or sponge, then traditionally we would stiffen or consider a fusion. And a fusion is what? We use some of these props here.
Correct.
And
show and tell.
So in show and tell here, these little bars are meant to kind of compress and help.
So hold that on that side of the mic if you could, because I don't want to.
And add a little bit of stability and compressive forces to try to knit those two bones together so they don't wobble or cause pain by not cushioning their certain level.
So that's what that is right there? That's a fusion?
Correct. So this is called a fusion. And so essentially what you're doing is you're fusing the multiple joint segments. So there's 32 bones that make up the spine, all the way from the head all the way down to the sacrum, the butt. And so all those bones move small degrees on top of each other. So by locking up one segment, we figured out that if this joint segment is your culprit for your pain and we locked it up, your pain actually got better. And this is the history behind why we decided fusions were the way to go. Because everything's segmental, it did not affect range of motion dramatically, right? If you fuse your knee, you wouldn't be able to walk straight. So the knee is a very important joint.
Or if you remember Chester on Gunsmoke, you walking stiff like that. A lot of young folks don't know him.
But in this setting, because there's so many joints that have small degrees of motion with each other, the fusion was the first thing that was tried because it was much easier than replacing those joints.
And how long have you been doing fusions?
So historically, medical personnel have been doing fusions since the early 1900s.
Okay, wow.
Yeah. But recently, and then I say recently as in the last 10 to 20 years, there's been a lot more advances on joint replacement devices for the spine.
Really? Like a knee replacement? You do a spine, something?
Correct.
Really?
In this case, a disc replacement.
A disc
and that's
replacement.
what we're going to compare to a spine fusion. But before we talk about disc replacements and what they can do, how long would I expect to need to recover from a fusion?
Right.
And then, what things would make my fusion slow to progress or even fuse at all? I mean, I got to stop my Marlboros and what kind of restrictions am I going to get? How much work am I going to miss, or how long can I vacation before I have to go back to driving my bus?
So with the fusion, the whole goal is that this screws and rods that you're seeing here is a scaffolding. This is not going to be there to hold everything in place for the rest of your life. The scaffolding is there because we want bone to grow across that gap. That's what the fusion is. A fusion means that you're fusing the bone above to the bone below by growing bone between that gap. And how does that bone grow? It immobilizes. So this scaffolding will immobilize that segment so there's no longer any motion there. We put bone graft in that area. For that reason, the patient cannot be smoking because that's going to inhibit bone growth from this part of the spine. So no smoking. We have to limit activity afterwards. Typically, some surgeons, and this is debatable, still have patients wear braces after a fusion, and some don't. And there's really no data on one way or the other, but really it's a matter of how much tension you're going to put at the forces at the point that you just did this fusion on.
And how long does it take for fusion to take effect?
So classically, an actual bone growth is about 9 months after the surgery, but classically you can get some fibrous union after about 3 months.
Okay.
So fibrous union is just a soft growth of tissue that's fibrous in nature, not solid, but enough that it's holding everything in position. And then the bone calcium will be depositing as time goes on through the course of life. But ultimately, that fusion is really just isolated to that joint segment. So what do you think is going to happen if we locked up this segment and let this person go walk around and run around?
Would shake free?
Wrong.
No.
So what happens is...
Probably cause a little more stress above and below.
Exactly. So because...
Where that segment doesn't move, increase force at the level above.
Oh,
and below,
so it creates another problem?
Correct. So it creates a second problem or secondary problem because now you've locked up this segment. It's a fulcrum. You know what a fulcrum is? It's a large, solid piece of solid material that is now moving around a joint adjacent to it. And so now that joint has a lot more forces that normally would have been applied at the force where we did the point we did our surgery. Now those forces are additionally applied above and below, and those will degenerate quicker because of that surgery.
So even if they recommend, well, maybe we do 2 levels in the beginning, and then say that second level might need something later, we better do it now.
Right.
Then you're still creating
an
that
additional
stress
problem
at the level above that, right?
Correct.
So, and that would be what? You're talking
10 to 15 years. So about 10 to 15 years.
So longer down the road.
Correct.
But, certainly something that's somewhat predictable, though.
Correct. And the reason it's predictable, and now I can tell you from quoted articles, it's about 25% of the patient population will experience an adjacent level issue. However, it's still about 10 to 15 years down the road, and the reason is because, people are still active. This is a weight-bearing bone. It's like the femur. It's always going to have to bear weight. And so as that happens, you can see that this is still going to need to be moving because they have to get up and move around. And so that forces, the tension is going to be there. And that degeneration causes us to have to do further surgeries in the future. And that's why I don't know if you've read any articles recently, but Tiger Woods is on his 16th spine surgery now.
Wow. So I'm getting the feeling, maybe I'm being set up or not, but I feel like, is this the old way and now there's a new thing we're going to talk about? Or is this still like the common practice?
It still actually is the common practice. And partly it's because of what is tried and true. We know that this works for 75% of the population without the adjacent level issue. There's still a 25% chance, up to maybe 30% chance for that adjacent level issue to still develop. So what I'm going to be talking about a little bit here right now is this disc replacement device.
Okay.
And so these are relatively newer in construction, but as you can imagine, the spine is not a very simple, straightforward structure. It's not a very tried and tested joint motion segment. And in everybody's body, they're moving differently. But to come up with a off-the-shelf model of a joint replacement device that works for all patients, it's still not also going to be 100% home run, if you will.
Got it.
And certainly the neck and low back have different sizes, different demands, different techniques that might be needed to place those replacements in the proper location, right?
Correct.
And so again, it takes quite a bit of expertise because your spinal cord, you mentioned that.
Yeah.
If you hold it on the end, I think people can see on the top.
Correct.
The opening behind the discs is where the spinal cord is. In this model, it's yellow.
Yeah.
So there are certainly we call them gators, but there's certainly some dangerous structures that are in the area. Some of them in the front, some in the back of the spine. And if we said then, let's contrast the spine fusion option with disc replacement option, then we would then say, tell us the advantages of that and some of the disadvantages, because there may be a little of both.
There certainly are disadvantages as well. So essentially what we're trying to do is we just talked about why the fusions aren't always 100% success rates.
Yeah.
And it's mostly because of the adjacent level issues. And so what we're trying to do is preserve motion now at that segment. So the surgery to decompress the nerves, restore height, lock, or at least immobilize a certain area that's a little bit pathologic is still done. It's a matter of what we place in between those two bones. And so essentially with this one, what we're doing here is we're trying to replace between the bones with a disc replacement device. So I'm taking this apart. This is not really how it works, but it's basically a ball and cup mechanism, as you can see, and it's the center of that disc space on purpose because that's where the center of rotation normally is. Now, in reality, our bodies, it's actually a little bit more further back. So we try to get that to sit further back so that when they're moving this way, it doesn't spit out this way. The biggest complication is because it's a mobile joint now, it can spit out. versus a fusion where we actually locked it into the bone above and bone below.
And the lining, that thing we call the annulus,
Correct.
is like a little barrel-shaped lattice that should be okay in the front. You don't, if you're coming into the back of the back, we don't open that front area, but it still is at risk if that force, pushes forward from a disc replacement.
So not necessarily. So what happens with the disc replacements are all disc replacements as of right now are placed anteriorly. So in order to do a lumbar disc replacement, we have to have access from the front of the spine. Why is that important? If you think about where the column of the spine is, where all the weight is going to be bore, it's up in the front. So in order to get here, you come from the front. If you came from the back, you're going through no man's land, if you will, the spinal canal. You can't get a big, large bone, cup and a ball model all the way around into that spot. And you can't get it where you want it to get. But in the front, you have a nice window of opportunity right up front like this that you can remove that disc, put in a spacer, and that spacer is actually a combined ball and cup kind of device that goes into that area.
Now, do you come through the front for that?
Yes. So
really?
Do you have a surgeon expose that area for you? They move the big old arteries called the aorta and thing out of the way and
Correct.
say, get me down to the spine, and then you walk in and do like the closer in baseball.
Exactly.
Like you do all the tough work with the bases loaded in the eighth inning. I'll walk in, get the last out, and pop the disc in.
So for the lumbar spine, absolutely. You absolutely need to have an exposure surgeon. Or if you have a spine surgeon that's done so many of these by himself or herself and has the experience with getting down to that part of the spine, then that's great. But for us here in the Dayton area, none of them that I know of can do them by themselves. And so for the most part, we've been using one of the community surgeons in the area that gets us access here. So we don't end up seeing any of the bowels. We do have to move some of the vasculature, which is what he had mentioned, the aorta and the vena cava and the iliac veins, if we're going down by L4, L5, because that's where they kind of split. So from a risk standpoint, L5, S1 is actually the easiest levels to do. It's the lowest level, and it's a very easy level to do. And the reason it is because the bifurcation where those two veins split is right over this spot. So that gives me a perfect window to get down to this lowest L5S1 area.
So what is, I've heard people get injections of some type of fluid into the spinal cord or into the disc. What is that? Is that what we're talking about here at all?
No. This is an actual disc replacement device. Okay. The injections you're probably referring to are steroid injections that we will typically do inside of a joint to decrease the inflammation.
Oh, I thought it was like a foam that went in there kind of like and pumped. There's nothing like that.
No.
Okay. I must be making things up.
Steroids will also help pinpoint for your surgeon which small joint called facets or little hinge joints in the back where the problem is coming from. They help diagnose, hey, that took care of my pain. That tells Dr. Patel, hey, that may be where we have to look someday.
But that only lasts so long, right?
Correct,
because it may not fix a ruptured disc, it may not fix a bone spur or anything that's pushing. Remember, these are usually related to the nerve or the disc being unhappy. You're not always able to complete that with just a shot.
Wow, okay.
And then there are times where you might also be thinking in the foam world where a lumbar vertebra or a back bone actually breaks, and from osteoporosis or trauma, sometimes they'll inject a cement or some type of hardening device to kind of restore the square or
maybe that's what I'm thinking of.
Maybe restore, and that takes away some of the back pain when sometimes these bones break from osteoporosis, and those are kind of a different topic dealing with what's called a lumbar fracture or a crack in a bone from osteoporosis or trauma.
So is there a rule of thumb that somebody listening at home, a viewer, would have back problems that they might be able to say, okay, if I do this or do this and it hurts, it's this problem? Is there a way to test this by doing a certain?
Unfortunately, no. And the main reason is because it's such a dynamic and complicated part of the body. There's so many muscles and joints in that area that it's so difficult to really tease out where the problem level is, right? And some people can have multiple levels of problem areas. And so the degeneration never only happens at only one level, typically.
Really?
By the time we come and see them or they come and see us, it's rare that only one level has been affected. It's usually that happened, they went on with life, and now the next level is affecting them, and they went on with life, and they went on to, same thing happens. It just keeps going, and then they come in, and now their legs aren't working like they used to. And then we find out they've got compression of the nerves in their spinal canal, but it's at multiple levels. And now, so how many levels are we going to do? Are we going to do all of them? Are we going to do some of them? And so a lot of times we'll do the injection. We'll use that injection as both a treatment and a diagnosis to figure out which level is the best one for us to fix, or all of them.
And how long, if you do a fusion or
a disc replacement.
How long am I out for? How long am I in the hospital? How long am I out for?
Essentially they're very similar from a recovery standpoint, believe it or not, except that the disc replacement device, as long as it's successful, will give you more mobility at an earlier phase. And so you're typically in the hospital overnight for both of these procedures. Some of the cervical ones are being done outpatient. The lumbar ones, not so much because of the access coming in from the belly.
Yeah.
And so, most of the time, this is debatable as whether people wear braces after a disc replacement or not. We don't want any of this hardware to move around too much. We want some of those. So a lot of these are fastened in with little ridges. And I don't know if you could see, there's a little keel in the middle that's going into the bone above, almost like a shark fin.
Yeah.
So that shark fin or keel is sitting inside the bone above. If they're moving around quickly after surgery, that can wiggle around and become looser. So we sometimes do want people to wear a brace afterwards temporarily to let that heal inside the bone. So typically we're looking at a month really for a lot of that. And then once a month hits, we usually start with physical therapy to start breaching those barriers of range of motion.
Yeah, well, I was going to wonder, in the Midwest, we have no mountain range or ocean, so you're going to have questions about golf and tennis, some of the racket sports. How long are we talking about staying out of those activities after a procedure like this? So
unfortunately, those are pretty weight-bearing activities. And so we would recommend walking after about a month, but the twisting motion that's involved with golf, same thing with tennis, is really where you're going to start putting a lot more forces on this disc replacement device.
Shot, let's call
Basically,
it.
yes.
We do the same thing with, we talked about ACL surgeries in the knee, Tommy John, elbow, some of these big procedures, rotator cuffs. I mean, you're basically going to need 9 months to a year to really let the body heal to live to play another day. And a lot of times you see it in your athletes, they all come back bigger and better than ever, but they know that like sneaking out to hit drivers isn't good for their back, right? I mean, they're not helping themselves when they're trying to get something to knit together or in the disc space replacement category, like, move or spit out, and that would be not too good, right?
No, absolutely. And I think part of the issue is the unconscious motion at this segment level, right? Yeah. So when you are using your hand and you're doing the Tommy John, there's an unconscious motion of that level that is happening and the force is applied to that Tommy John surgery. Same thing happens in this scenario. And same thing with golf. When you're swinging like that, all of that's unconscious. You play golf, Terry?
I have hit a ball and I'm not very good at it.
Okay. But when you're swinging and rotating, you're putting so many forces on your back and you're not focusing on that. You're focusing on that ball and where it went. Do you see what I'm saying? And so a lot of folks will put tension on that spine, and that's why I typically say 6 months. That's my personal answer when people ask.
Just curious, how many of these do you do in a week? If you had to guess.
We have about 3 surgery days, so I'm looking at probably about 2 to 3.
Okay.
And do we do more than one level, or not too often? Right.
So right now, from an approval standpoint, because you're making things hypermobile potentially if you're going that many times, because you will have to take down a lot of ligaments up front, like you said, the annulus and all the ALL, which is the anterior longitudinal ligament. There's a ligament that goes all the way up from down the front of the spine, from the head down, and you got to take that apart to put this in. So that itself provides some support. So now you're putting that disc replacement device in there. So essentially, that's going to cause some issues with motion, and you can't really do more than 1 or 2 levels. The lumbar spine is 1 level at a time. The cervical spine, depending on the insurance company, will get 2 levels approved.
Anything fancy coming down the line that might make life easy for surgeons like to do stuff like this?
Well, there's robots, and so that certainly will help. I still think from right now, this is going to be, physics and just access and doing the spine surgery the way we've been doing it is successful.
Yeah, I hate to plug a company, but I'm a consultant for a virtual reality company.
Yes.
That actually we've used on hips and knees, but they also have fired these things called pedicle screws.
Yeah.
So we talk about fusing some of the little rods is one way, but these virtual reality sets you see everybody wearing and looking at Hawaii. But we as surgeons, they can program with CAT scan and imaging the spine to where we drill for these screws placements, and it's very important. Dr. Patel will tell you that placement of that screw is critical because the nerves that go to your legs can be pinched by a screw, and then that isn't good. So the virtual reality, which is a new technology, is helping guide the use of some of the screw placements in the spine, and the cadaver studies show 15 out of 15 perfect placements. And it's almost like a sniper with a red and then all of a sudden a green cross saying drill here. And this is the perfect trajectory for placing a drill followed by a screw, which then holds that segment. And that's a type of a fusion where you're stiffening a level or two of the low back. And that part is a newer technology that, again, you ask what's coming down the road. Well, technology is always helping. Yeah. It's never always the best thing to be the first person or the last, maybe.
Right.
But I think we all look at these articles. We look at what's called evidence-based medicine, try to find out if they're using it. Does it work? Are there cadaver studies that show where these things went? Were they accurately placed? So I think we all want to do things more accurately and better. We also have like a big robot coming in a room, and is that going to increase our risk for infection or things that we don't want in a room, and how many more people are in the room? So a surgeon has to look at all those parameters before deciding, am I going to jump on the latest, greatest thing, or what I've had all this training and I've learned over the years.
Right.
Yeah. I mean, the next level of virtual reality is augmented reality, which they are doing that now too. So the difference obviously would be that you actually have the normal environment right here in front of you, and then a screen overlay where now that virtual reality is overlaid on the actual patient.
I saw that this weekend at the Apple store. They were doing augmented reality. It's amazing. So as we land this podcast, if somebody wants to find you and talk to you, how would they go about doing that?
So the best way to do that is to look us up on Kettering Brain and Spine. You can just Google Kettering Brain and Spine. We're located right off of Southern Boulevard, off of 75.
Okay.
And I also work at Grandview Medical Center, which is now known as Kettering Health Dayton, historic osteopathic training grounds, of course. That would be the best way to get a hold of us.
All right, great. Any words of wisdom before we sign off?
Well, we want people to look at the Bone and Joint Playbook.
Of course.
On all of the sites that service podcasts like Spotify, Apple, iHeartRadio, the YouTube channel. So if you like us, please
But who do we
us.
thank?
And we always thank Ted's Dressing, our sponsor. They are
the best dressing ever.
The best dressing ever. They're dairy-free, gluten-free, sugar-free, and
it is good
now
stuff.
available online.
And
we have
at
to
Dots,
say, thanks, Ted.
Thanks, Ted. That's correct.
Ted'sDressing.com.
All right, well, this has been the Bone and Joint Playbook, and I want to thank our guest, Dr. Patel, and, of course, Dr. Urse for being
Appreciate
Dr.
you.
Urse, and we'll see you again real soon on the next episode of the Bone and Joint Playbook with Dr. John Urse. Thank you.
Thanks again for joining today on the Bone and Joint Playbook with Dr. John Urse. If you would like to be a sponsor of the Bone and Joint Playbook, please contact trilevelrecords.com.